Surgical Insights Hub. Today we're diving into a critical but often overlooked complication in spine surgery, iatrogenic iliac artery injury during posterior lumbar procedures. As one expert put it, one wrong angle, and you're dealing with a life-threatening bleed before the dura is even closed. This really is one of those zebras among horses in the OR. It can drastically change the trajectory of a seemingly routine operation. You might be thinking, how common can this really be? And that's exactly part of the paradox we'll unpack. Our mission today is to illuminate the critical details, the anatomy, the mechanisms, diagnosis, and management, and crucially, prevention strategies too. It's about being prepared for the rare so you can act decisively when it really matters most.
Indeed. It's a profound vulnerability, isn't it? In what seems like such a standard move during surgery. This deep dive hopefully will offer you the precise knowledge needed to identify and manage this insidious complication, making sure you're ready when the unexpected occurs.
Okay, so we've called this a zebra. But before we jump into managing it, let's really get a handle on just how often this elusive complication pops up, and maybe why it's even harder to track than you might think. What's the real incidence, and what's this concern about underreporting all about?
Well, the reported incidence for major vascular injury during posterior lumbar disc surgery is quite low on paper. We're talking maybe 1 of 5 cases per 10,000 procedures. Some analyses push that range a bit wider, maybe 3.5 to 17.3 per 10,000.
Right.
But while those numbers seem small, the consensus, among the sources is that the true incidence is likely much higher, probably significantly underestimated.
Higher. Why is that? Why the discrepancy?
The reason is absolutely critical. It's because not all injuries manifest as, an acute crisis right there on the table. Many present much later, weeks, months, even years down the line. Things like pseudoaneurysms or arteriovenous fistulas.
Yeah.
And they aren't always immediately linked back to that original surgery, this bimodal presentation. That's a huge diagnostic challenge.
Right, so it doesn't always declare itself immediately, and it's rare to begin with. So where exactly are these danger zones in the spine, the spots that put these vessels at such risk during a posterior approach? And how thin is that barrier we're talking about, really?
The anatomical crucible, as one source really nicely described it, is primarily the L4, L5, and L5S1 intervertebral disc spaces. One comprehensive study found that an astounding 84.4% of these iatrogenic vascular injuries happen specifically at L4, L5.
84%. Wow, that's specific.
It is. And what's striking is why. The left common iliac artery is most frequently injured at L4, L5s, simply because its path courses immediately anterior to that disc space. It's right there, directly in the line of fire for surgical instruments coming from the back. Now, at L5S1, the anatomy shifts slightly, and the right common iliac vessels become more susceptible.
Okay, so location matters hugely. And the barrier you mentioned.
The barrier. It's incredibly thin. The only thing separating your surgical field posteriorly from these massive vessels anteriorly is just the annulus fibrosus, that tough outer ring of the disc, and the anterior longitudinal ligament, the AL, that supportive band running down the front of the spine.
Just the annulus and the ALL.
Yeah.
That's astonishingly little protection.
Precisely. It's an incredibly tenuous barrier. And you have to consider, in patients with chronic degenerative disc disease, it can be pathologically weakened, thinned out. That makes it even easier to inadvertently breach during disc removal.
So a common tool could become dangerous there.
Exactly. It's a prime example of how a very common tool, like a pituitary rongeur, which surgeons use all the time to grab disc material, can become, frankly, a lethal instrument. But only in this highly specific anatomical context, if it's not handled with extreme precision and awareness of that anterior limit. The goal of getting all the disc out, complete decompression, often encourages pushing that instrument deeper. And it's an instrument with no safety stop, heading towards a major vessel protected by a thin, often diseased barrier.
Right. So the pituitary rongeur is often the culprit. The annulus is the weak spot. But, the OR isn't static. It's not just about being close. What are the actual actions, the specific instrument uses that most often lead to these injuries? And how does something like patient positioning play into this risk?
Yes, the mechanism. The most commonly implicated mechanism is, just as you suspect, the inadvertent advancement of that pituitary rongeur, pushing it beyond the posterior confines of the disc space during the discectomy. The surgeon's aiming for complete disc removal, right? So they might push the instrument just a bit too far through a weakened annulus and the AL, directly perforating the vessel lying just anterior. Now, this isn't necessarily negligence, it's important to state that. It's more of a recognized inherent procedural risk, which helps explain why even very experienced surgeons can unfortunately encounter this complication.
Okay, so it's inherent to the procedure and the tool. What about positioning? How does that become a, as you said, co-conspirator?
Patient positioning. It's a critical contributing factor. When a patient is prone, face down, especially with abdominal bolsters or on certain frames like the Wilson frame, intra-abdominal pressure can go up significantly. This pressure effectively compresses all the retroperitoneal contents. It essentially pins the great vessels, the aorta, vena cava, iliacs, firmly against the anterior vertebral column.
Ah, I see. So it reduces any potential space or give?
Exactly. It significantly reduces the already very narrow margin for error. There's just less wiggle room.
So it's not just about the space itself, but how that space gets compressed. That sounds like it could create a kind of deception.
It absolutely can, and this is where it gets even more concerning. That same positioning, that increased pressure, can create a temporary tamponade effect. It can actually mask an active bleed. The external pressure helps control it temporarily.
So the bleeding is happening, but you don't see the consequences immediately.
Precisely. The catastrophe often only becomes fully apparent when the patient is turned back supine onto their back. That external pressure is released, and suddenly the masked hemorrhage reveals itself. This highlights the really insidious nature of this complication. The surgeon might finish the case, close the wound, thinking everything's fine, only for disaster to strike moments later in the recovery room. That's a profound diagnostic trap.
That genuinely sounds like a nightmare scenario. A previously stable patient, maybe during closure or right after, suddenly becomes hemodynamically unstable, hypotensive, tachycardic. But there's no obvious source of bleeding in the surgical field you just closed. What are the immediate red flags then in the OR?
Yeah, that's the critical question, isn't it? How do you diagnose something that isn't presenting where you're looking? The classic acute presentation is that sudden, profound, and otherwise unexplained drop in blood pressure, rise in heart rate, hypotension, and tachycardia. But, and this is the really challenging part, there's often a conspicuous absence of abnormal bleeding in the operative field itself.
Because the injury is anterior.
Exactly. The injury is to an anterior vessel, so the massive hemorrhage is contained within the retroperitoneal space. It's bleeding behind the abdominal lining. You won't see it from your posterior incision. This can lead to critical, dangerous delays in diagnosis, as the team might consider other causes first: anesthetic issues, maybe cardiac problems.
Are there other signs, maybe things the anesthesia team might pick up on?
Yes, absolutely. Ancillary signs for the anesthesiologist are crucial here. They might see a sudden drop in end-tidal CO2. That's a key measure of exhaled carbon dioxide. And a sharp drop can signal seriously poor blood flow or circulatory collapse. Also, decreasing oxygen saturation, or perhaps noticing the development of a tense, distended abdomen as it fills with blood.
Okay, that covers the acute dramatic presentation. But what about those delayed ones you mentioned? Pseudoaneurysms, AV fistulas. What are the more subtle signs there, maybe weeks or months later, that could point back to a previous spine surgery?
Right, because not all injuries result in that immediate crisis. A smaller tear, maybe one that's partially contained, can lead to these delayed complications. And we're talking weeks, months, sometimes even years later. There's one case report I recall, diagnosis wasn't made until 60 months. That's 5 years post-op.
5 years. Incredible. So what do those look like?
Well, pseudoaneurysms, PAs, those contain blood sacs outside the artery wall. They might present with a delayed onset of abdominal pain, maybe back pain, sometimes a palpable, pulsating abdominal mass, or even new neurological symptoms in the legs from nerve compression by the mass. Then you have arteriovenous fistulas, AVFs. That's an abnormal connection between the injured artery and an adjacent vein. These create a really distinct syndrome. You should think high-output cardiac failure. The heart struggles to keep up with the short-cutting blood flow. Also, progressive shortness of breath on exertion, maybe leg swelling, unilateral or bilateral, and often a new continuous machinery-like brood, sort of humming sound, or even a palpable thrill over the abdomen or back.
Wow, very different presentations. So with all this variation, a high index of suspicion seems absolutely paramount. How do you actually confirm these injuries? What are the go-to diagnostic tools?
Suspicion is definitely key. Any unexplained hemodynamic instability after a laminectomy or discectomy must be considered a vascular injury until proven otherwise. Now, for the acute unstable patient, time is critical. An immediate exploratory laparotomy opening the abdomen can be both diagnostic and therapeutic. You find the bleed, you fix it. But for stable patients, or those presenting with these delayed symptoms, computed tomography, angiography, or CTA is really the diagnostic modality of choice now. It gives you incredibly detailed pictures of the blood vessels, pinpoints the injury, and is crucial for planning treatment. Conventional angiography, where dye is injected directly into the vessels, is also essential, particularly if you're planning an endovascular repair.
Okay, so CTA for stable or delayed, maybe straight to the OR for unstable. It links back to that bimodal presentation you mentioned.
Exactly. If you look at Table 2 in the source material, it really highlights those stark differences. Acute lacerations presenting with shock, right there in the OR, versus these delayed PAs or AVFs showing up weeks, months, years later with symptoms like heart failure, often presented to a cardiologist or primary care doc, not the original spine surgeon. It really underscores the need for broad awareness of this complication across different medical specialties.
Makes sense. Okay, so you've identified the injury. What are the primary management strategies now? You mentioned open surgery for unstable patients. How has the overall landscape changed? Are there less invasive options that are gaining ground?
Yes, the management landscape has significantly evolved, thankfully. For those acute, unstable patients with massive retroperitoneal hemorrhage, immediate open surgical repair via laparotomy still remains the gold standard. It has to be. The primary goal is rapid control, getting clamps or tourniquets proximal and distal to the injury site to stop the bleeding. Fast. Techniques then range from primary suturing for a simple, clean laceration to maybe patch angioplasty, using a patch of vein or synthetic material for larger defects. Or even interposition grafting, cutting out the damaged segment and replacing it, often with a Dacron tube graft, for really extensive damage.
But that sounds like a major undertaking, especially in an already critically ill patient.
It is. And while it can be life-saving, this open approach carries very high morbidity and mortality rates. That reflects both the patient's critical preoperative state, they're often in shock, and the sheer physiological insult of a major emergency operation. Mortality rates for these acute lacerations are reported somewhere between 20% and 38%. It can be devastatingly high, up to 65% in some series, particularly if the diagnosis was delayed or initially missed.
65%.
That's sobering. So for patients who aren't in that immediate life or death crisis, how do things change?
This is really where the paradigm has truly shifted. Endovascular techniques have completely revolutionized management. They're now considered first-line therapy for pretty much all hemodynamically stable patients. And certainly for those delayed complications like pseudoaneurysms and AVFs, the cornerstone of endovascular treatment is the percutaneous placement of a covered stent graft.
So going in through the arteries, not opening the abdomen.
Exactly. The device, a stent covered with graft material, is delivered via catheters, usually inserted through the femoral artery in the groin. It's navigated up to the site of injury under X-ray guidance and then deployed across the defect. It essentially creates a new, intact lumen within the damaged artery, sealing the hole, excluding the PA or AVF from circulation, all while maintaining blood flow through the main vessel.
And the advantages.
Oh, the advantages are profound. Significantly lower morbidity and mortality compared to open surgery. Less physiological stress, faster recovery. This shift means that patients who previously might have been considered too high risk for open surgery, maybe managed medically with observation, can now often safely undergo an elective endovascular repair, preventing potentially serious long-term consequences like rupture or heart failure.
That's a huge advance. So a clear preference for endovascular when possible. Are there situations where you might combine approaches, maybe in emergencies?
Yes, absolutely. Modern management is often flexible, sometimes involving a hybrid approach. We try to leverage the strengths of both open and endovascular techniques, tailoring it to the patient's stability and, frankly, the resources available at the institution. For example, in an emergent setting, there are endovascular tools like Reboer resuscitative endovascular balloon occlusion of the aorta.
Reboer, how does that work?
It involves rapidly placing a balloon catheter, again, usually via the femoral artery, up into the aorta above the injury site. Inflating the balloon temporarily stops major blood flow downstream, acting like an internal tourniquet. This can provide crucial temporary hemorrhage control, stabilizing the patient and buying precious time. Time to get them to definitive repair, whether that ends up being open surgery or a more complex endovascular procedure. The decision-making algorithm is really dynamic. It depends on the patient's response, the nature of the injury, and the immediate availability of a skilled vascular or interventional radiology team.
So it's very much a team effort and depends on the specific scenario.
Precisely.
Yeah.
And if you look at Table 3 in the source material, it lays out that comparison quite clearly. Open repair generally reserved for unstable acute cases associated with higher mortality, versus endovascular, preferred for stable patients and delayed presentations, offering significantly lower morbidity and mortality via a minimally invasive route.
Okay, so managing the immediate crisis is one thing, but you hinted at long-term issues. Does survival always mean full recovery? What kind of long-term morbidity do patients face after they've survived an iliac artery injury and its repair?
That's a really important question. And unfortunately, no, survival doesn't always equate to a full, uncomplicated recovery. Even if the patient survives the initial event, the potential for significant long-term morbidity is substantial. In the acute phase itself, beyond the hemorrhagic shock, they face the consequences of massive fluid resuscitation. This can contribute to things like abdominal compartment syndrome, where the pressure builds up from that large retroperitoneal hematoma, and that in turn can lead to multi-organ failure, with acute kidney injury being a particularly common problem.
Right. And what about issues specifically related to the affected leg or limb?
Limb ischemia is a major concern, definitely. It can happen either from the initial arterial injury cutting off blood flow or from subsequent clot formation, thrombosis, even after repair. This can cause acute lower limb ischemia, which might require emergency fasciotomy surgeries to cut open the muscle compartments in the leg to relieve pressure and prevent permanent damage. In the most severe cases, despite best efforts, it can result in permanent muscle damage, chronic nerve injury, persistent pain, or even tragically limb loss.
And the repair itself can cause problems down the line.
Yes, that's what's particularly striking. Even a technically successful repair can introduce new long-term morbidities. Take endovascular repair, for instance, especially if the stent graft have to cover the origin of the internal iliac artery to get a good seal, which is sometimes necessary. Patients can later experience buttock claudication, that's ischemic pain, like a bad cramp, in the gluteal muscles when they walk or exert themselves, due to reduced blood flow to that area. One study actually reported this in about 32.6% of patients after certain types of iliac endovascular procedures.
Over 30%. That's quite common.
It is. And other potential long-term issues with endovascular grafts include things like endoleaks, where blood finds a way to leak back into the excluded aneurysm sac or around the graft. Also graft migration, where the stent moves from its original position, kinking of the graft, or thrombosis, clotting off the graft. These often require surveillance and sometimes secondary interventions, further procedures to fix the problem. Open repair isn't without its own long-term risks, either related to major abdominal surgery like adhesions or hernias. Though one study did show about 90% freedom from needing a secondary intervention at 5 years for open repair of ruptured iliac aneurysms, which is pretty good. It really makes you think. The definition of a good outcome needs to shift beyond just mere survival.
Yeah.
We have to consider long-term functional status and quality of life.
Absolutely. Quality of life is key. So given how devastating this can be, both acutely and long-term, let's talk prevention. What are the key strategies? How do we identify the patients who are most at risk before surgery? And beyond the individual surgeon's skill, what about institutional safeguards?
Prevention starts with proactive identification of risk factors. That's absolutely the first step. Patient-specific factors are important. A history of previous abdominal surgery or previous spinal surgery at the same level is a big one. Why? Because it can create dense scar tissue, adhesions, that bind the great vessels more tightly to the anterior spine, making them less mobile and more vulnerable.
So less give during the procedure.
Exactly. Other factors include chronic degenerative disc disease, which we mentioned can weaken the annulus, but also cause peridiscal fibrosis, more scarring. Pre-existing vascular disease, like significant atherosclerosis, makes the vessels themselves more fragile. Vertebral anomalies, like large anterior osteophyte bone spurs, can distort the anatomy, and obesity can make exposure more difficult. Procedure-wise, as we discussed, surgery at the L4, L5 level carries the highest risk statistically for these posterior approaches. Revision surgeries are riskier than primary surgeries, and procedures requiring particularly aggressive disc removal with those pituitary rongeurs. And let's not forget, improper patient positioning, anything leading to excessive intra-abdominal pressure, is a contributing factor. You can find a good summary of these risk factors in, I believe it's Table 4 in the source material.
Okay, so identifying patient and procedural risks, but you mentioned this isn't just about individual skill. What about the system, hospital-level preparedness?
That's right. This really needs to be seen as a systemic responsibility, not just falling on the surgeon. Surgeon-level prevention involves meticulous technique, of course. Being constantly aware of instrument depth, avoiding overpenetration of that anterior annulus, and recognizing crucial red flags intraoperatively, like seeing any unexpected arterial bleeding coming from within the disc space itself that should immediately raise alarm bells. But institutionally, the source strongly emphasizes the need for formal, written standard operating procedures, SOPs, specifically for managing major vascular injury. These should be coupled with existing major hemorrhage protocols, MHPs.
And everyone needs to know about them.
Absolutely.
Yeah.
All OR personnel surgeons, anesthesiologists, nurses, techs need education and regular training or drills on these protocols. Crucially, institutions performing spine surgery need to ensure immediate availability of emergency vascular instrument trays right there in the OR suite or very close by. And very importantly, there should be a prearranged formal agreement with a vascular surgery service, either in-house or at a nearby facility for immediate consultation or rapid patient transfer if needed. Multidisciplinary team discussions for cases identified preoperatively as being high risk are also highly recommended. Planning ahead.
That proactive system-wide approach sounds essential. What about the medico-legal side of things? If an injury does happen, what should surgeons and institutions be aware of?
It's an important point. What's interesting from a medical legal perspective is that the injury itself may not automatically constitute negligence. Why? Because as we've discussed, it's often recognized as a known, albeit rare, complication that can occur even when the surgical technique is appropriate. However, the medical legal focus shifts dramatically, and often critically, to the timeliness and appropriateness of its recognition and subsequent management.
So it's less about the injury happening, more about how it's handled.
Largely, yes. A failure to diagnose a vascular injury promptly, or a significant delay in initiating appropriate management once it's suspected or confirmed. That would very likely be seen as a deviation from the accepted standard of care. Informed consent is also paramount here. The specific risk of major vascular injury, catastrophic bleeding, potential paralysis, and even death must be explicitly discussed with the patient before surgery. And this discussion needs to be clearly documented on the consent form. It can't just be assumed under general complications. And looking at the bigger picture, the standard of care itself is evolving. A hospital that allows complex spine surgery to be performed without having adequate vascular backup readily available, or without established emergency protocols and transfer agreements in place, could potentially be viewed as providing a substandard environment of care. This could open the institution itself to liability for systemic failures, not just pinning blame on the individual surgeon.
That's a really crucial point about institutional responsibility. Wow. This deep dive has truly highlighted the critical paradox of iliac artery injury and posterior lumbar spine surgery. It's a rare event, statistically, happening in a very common procedure, yet it carries these potentially devastating, sometimes insidious outcomes.
Indeed. The key takeaway is crystal clear, I think. Rare does not mean ignorable. You simply can't afford to ignore this possibility. And that bimodal presentation we talked about, from the acute shock on the table to the delayed, subtle onset of high-output heart failure, years later it demands unwavering vigilance. Vigilance not just from spine surgeons, but across specialties and over the entire timeline of patient care.
So, distilling this all down, what are the absolute key clinical pearls that our listeners, surgeons, residents, or teams should really carry forward from this discussion?
Okay, let's summarize a few high-yield pearls. Clinical pearl 1. Always suspect a retroperitoneal bleed if you encounter sudden unexplained hypotension during or immediately after a posterior lumbar surgery, especially when there's no obvious bleeding in your surgical field. Think anterior injury. Clinical pearl 2. Computed tomography and angiography CTA is your gold standard diagnostic tool for stable patients, and particularly for those suspected delayed presentations like PAs and ABFs. Get the CTA. Clinical pearl 3. Have a robust vascular backup plan. Whether it's an in-house team or a clear practice transfer protocol, have that standard operating procedure, SOP, for major vascular injury in place, always. This is about systemic preparedness, not just individual skill. Clinical pearl 4. And remember the positioning effect. Patient positioning can mask a bleed. Be acutely aware of that potential tamponade effect from prone positioning, which might suddenly release when the patient has turned supine. Watch closely during that transition.
Those are incredibly important practical takeaways. Thank you. Thinking about the future now, what's next? What advancements might help us better manage or even prevent this critical complication?
Well, looking ahead, future efforts really need to focus on a few areas. Integrating technology for better real-time intraoperative visualization. Imagine being able to clearly see those anterior vessels in relation to your instruments during the discectomy. That could be game-changing. Also, developing more high-fidelity simulation models. These could be invaluable for training entire OR teams, surgeons, anesthesia, nursing, and crisis management for this specific scenario, practicing the protocols, and further standardizing those institutional safety protocols across all centers, big and small, making sure best practices are universally adopted. Ultimately, what we probably need is a multi-institutional, perhaps even international registry, to prospectively capture data on these events, really understand the true incidence, refine the risk factors, track long-term outcomes accurately, and use all that data to guide future evidence-based practice and maybe even new preventative strategies. This isn't just about avoiding one rare complication. It's fundamentally about pushing the boundaries of surgical safety and improving patient care overall.
The crucial goal. We really hope this deep dive has provided you, our listeners, with valuable insights and reinforced the importance of vigilance, preparedness, and systemic thinking when it comes to posterior spine surgery. We absolutely encourage you to share your own experiences, perhaps your institutional protocols related to this, with us or your colleagues, or maybe just consider how these insights might refine or improve your own practice. Join us next time on The Deep Dive, where we'll be...